Okay, Assalamualaikum warahmatullahi wabarakatuh. Dan selamat petang, boleh dengar tak?
Waalaikumsalam, Prof. Boleh.
Okay, Alhamdulillah. Okay, kita ada 36 orang yang dah join. So, since Google Meet tak boleh nak record dah, so I think we wait for another few minutes, maybe dalam 2-3 minutes. Kalau ada lagi yang tak join, dan kita terus start, ya. So, kita tunggu sekejap. Okay, so rasanya kita start je lah kelas pada hari ini. Again, Assalamualaikum warahmatullahi wabarakatuh and a very good afternoon to all. So dah lama tak jumpa untuk part 6. I think this is the first time I teach you this semester, and suddenly you all pun dah semester 6 dah. Tadi perasan ada few names, so rupanya dah semester 6. How fast time ni berjalan. So I just ask your class rep, dia kata kelas masih conduct as online classes. So kita continue je lah, kita buat NAB 608 ni as online. Kalau ada keperluan, if you really don't understand for certain issue, you want a face-to-face tutorial, so you just ask lah. So kita tengok sama ada keperluan ataupun tak untuk kita buat face-to-face, ya. So if I'm not mistaken, during COVID last time lah, masa the first COVID tu, I ada record all my MNT3 classes. So if you want to watch it kan, you boleh tengok yang previous class punya lah, ya. Basically I use the same slide, I have a similar content, but when we conduct live session like this, so it's more interactive lah, compared dengan you just listen to the recording session. Tapi plus minus is just about the same lah. Okay. Okay, so next slide. So this is the outline and also the outcome of this topic. So today's topic is MNT for pulmonary and also respiratory system. So outline ni kita akan go through the relationship between nutrition and also respiratory system. So you all akan tengok lah, kenapa, apa kaitannya, why is important of the nutrition dengan MNT for pulmonary. When we say about pulmonary, tahulah is involve our mainly is involve our lung. Macam sekarang I batuk-batuk ni, so it's involve that lah. And then we touch a bit about MNT in asthma, MNT in COPD, chronic obstructive pulmonary disease, and also MNT in cystic fibrosis. Okay, so the outcome of today's lecture is actually same with the outcome of the program of the course. Yeah. So at the end of the topic, students should be able to explain the pathophysiology and demonstrate understanding of medical care and also nutrition therapy. So we have this, kita ada lebih kurang 3 disease yang kita akan fokus: asthma, COPD and also cystic fibrosis, and other disease related to lung as well lah. Macam kita ada tengok juga sikit nanti lung cancer etc. So you should be able to explain the pathophysiology and you understand the needs of nutrition therapy for that kind of disease. And then you should be able to demonstrate an appropriate nutritional status assessment and intervention related to the medical conditions of on selected disease. Yeah? So if you get this kind of disease, apa nutritional assessment that you want to perform and what kind of intervention that you should provide to the patient. Okay? So macam bila kita dapat disease, I think sekarang you all dah MNT3 kan, dah tahu macam-macam disease dah you go through So you can see that most of the time you will see multiple diagnosis in one patient. So let's say lah kalau kita jumpa patient yang yang ada COPD, at the same time dia ada obesity, dia ada diabetes so how you manage that kind of disease So towards the end sepatutnya kita dapat tahulah macam mana nak perform a nutrition status assessment, and then you can develop the nutrition intervention with appropriate goals and objectives. So this is the aim of this course and also the aim of this topic. Okay, and untuk MNT3, I will provide you assignment on case study, and the assignment will be on this topic, MNT4 respiratory and pulmonary, because eventually I'll be teaching you MNT4 respiratory, MNT4 burn, endocrine and also lung transplant. So I think the most critical topic is this topic, MNT4 respiratory. So my case study will be given based on this topic. Okay. Okay, so we start with the introduction. Okay, so the nutritional status and pulmonary function are interdependent. So apa maksud kat situ So kita tahu nutritional status, pulmonary function interdependent this because of the healthy pulmonary system, it will support the body. Bila kita ada healthy pulmonary system, so the body can obtain the oxygen needed for cellular demands of the metabolism of our 3 macronutrients. Kita perlukan macronutrient, carbohydrate, proteins and lipid. So the provision of adequate nutrition to maintain optimal nutritional status assists in ensuring the growth and also development of the pulmonary system. This include untuk dia punya supporting structures as well. Okay, and then the nervous system, immune system, semua tu pun perlukan optimal nutrition. So kalau kita punya nutritional status and our ability to metabolize carbohydrates, proteins, fat, semua tu adalah directly related to the healthy pulmonary system. So itulah kalau macam untuk cakap pasal pulmonary ni kan, kita sekarang sihat, alhamdulillah sihat walafiat. So our breathing works is easy. Kita nak bernafas semua tak susah pun. Tapi kalau orang yang ada masalah respiratory, so dia nak bernafas pun susah So dia punya circulation of oxygen tu mungkin tak capai, tak dapat, susah, tak cukup So macam mana pula dengan effect dia punya metabolism juga So itu kaitannya lah antara nutritional status and also pulmonary system. So macronutrients fill using oxygen and also carbon dioxide, and malnutrition can evolve from pulmonary disorders and contribute to declining the pulmonary status. So nutrition is important for healthy pulmonary system, and those malnutrition kalau ada disorder dia boleh contribute kepada malnutrition. So you see, this is the pulmonary system, the anatomy and also physiology of our respiratory system. So we can divide our pulmonary system into two lah. Kat sini kita ada upper respiratory tract and also lower respiratory tract. Yeah. So kalau macam ada any penyakit ke kan dekat either URTI ataupun IRTI kan, macam selesema kan, sakit tekak, tonsillitis, common cold ya, semua tu pun adalah disebabkan masalah pada you punya sistem pernafasan lah. So you look at your pulmonary system ni, kita ada right lung and also left lung. So kalau right lung and left lungs ni, kalau any disease that involve lung, contohnya macam bronchitis, pneumonia, influenza kan, so ini ada menyebabkan lung lah, sama ada dekat bronchi ke dekat lung ni. You tengok kita ada bronchi, ada alveolus, alveolus ni yang small air sacs tu. Ada capillaries, which is responsible for the exchange of gases, oxygen and also carbon dioxide, and then kita ada alveolar juga dekat lung, So this is basically our pulmonary system, So kalau upper respiratory tract involves our nasal cavity sampai larynx, and then larynx trachea ke bawah adalah our lower respiratory tract. So ini adalah gambar pulmonary system, yang macam tadi lah, ini adalah lagi dekat lah, nak tengok cross sec dia kan, dia punya bronchi ni, ada dia punya left lungs ni kan, kat mana ini adalah alveoli yang bentuk macam anggur ni, yang mengandungi air sacs, small air sacs, and then kita ada this is the capillary, capillary that is responsible for the exchange of oxygen and also carbon dioxide, and then we have the surfactant layer yang tidak as protective to our So the gas exchange ni dekat pulmonary system ni is the major function that provide oxygen for cellular metabolism and also remove carbon dioxide. So kita punya lungs ni, our lungs, there are lined with a thin layer of water. So dekat water tu aja akan create the surface tension. Surface tension tu, kalau tengok gambar ni, itulah yang akan buatkan untuk lungs to expand and also allow for the gas exchange. And then the pulmonary surfactant is made by our lung and decrease the surface tension so that we can breathe. So lungs ni, dia punya function including to filter, warm and also humidify air, synthesize surfactant, regulate body acid-base balance, synthesize arachidonic acid and also convert angiotensin to angiotensin 2. So kalau kita dekat sini ada one of the functions of lung ni is to synthesize surfactant. So dia sebutlah banyak berbagai surfactant tu adalah bertindak sebagai untuk protective lah, dia decrease the surface tension. So itu yang membenarkan kita bernafas. So sometimes kalau dekat baby yang premature, baby dia tak well developed dia punya lungs tu, dia punya surfactants tak well developed, dia punya lungs tak mature enough. So itu yang sometimes ada problems macam bronchopulmonary dysplasia, ada masalah lung dekat immature kids, and so on lah. Okay. Okay, so kita count this is part of URTI lah. Okay, so you can read lagi pasal anatomy and also physiology of lungs. This is just a recap lah daripada apa yang you all dah belajar masa part 1, part 2 dulu ada belajar anatomy. Okay, next. Okay. So our lungs is protects against infection and also toxins. So kita punya lungs ni, dia sentiasa exposed to the air. So they also play an important protective role in our body that is linked to our immune system. So setiap kali kita bernafas tu kan, kita bukan kita tarik nafas kan, kita bukan hanya carry oxygen. So we know that every time we breathe, we also carry germs and also other foreign body, macam kita bawa juga pollutants. So as a result, our lungs are also designed to prevent unwanted materials from getting into our body. So how do they did that? So sebabnya dekat dalam kita punya lungs, kita ada trapped by sticky mucus substance which keeps airway moist. So mucus tu dia adalah mucus tu thick liquid lah, that is produced by the walls of the small airways to help keeps our lung clean and also well lubricated. So it is moved by tiny hair that is called cilia. So cilia is tiny hair that line our airways. And so they move back and forth as sweeping a thin layer of mucus of our lung, and then into our throat. So the unwanted material that will stick to the mucus, when it reach the throat, sebenarnya kita akan telan lah without we realizing. So kalau macam kita punya mucus builds up, ataupun kalau kita ada infection, we have inflammation, so we can just cough to help to clear it from the airways. So macam sekarang lah terasa banyak mucus kat sini kan, so maybe it's because inflammation, because it's due to post-COVID. So dia masih sampai sekarang masih sakit tekak ni, masih bercakap je macam ni, batuk-batuk. So the alveoli will engulf and also destroy the bacteria. So our structure of our lung is very delicate, and however it's designed beautifully. So it can be adapted to breathe, and at the same time it can also help to protect our body from harm. So that is the beautiful of our lung. Okay. So now let us see at the disorders that involve in pulmonary system. So we can divide it into primary and also into secondary. So contoh primary disorders of pulmonary system, contohnya adalah TB, bronchial asthma, and also cancer of the lung. So that is we call as primary disorder. And secondary disorder is when it's associated with other diseases, such as when it's associated with cardiovascular disease, obesity, HIV, sickle cell disease, scoliosis, etc. And the conditions of disorders, it can be acute or it can be chronic. Contoh acute condition macam aspiration pneumonia, airway obstruction from food. This is also part of pulmonary disorder. Macam makan kacang ke kan, and then tak boleh bernafas. So that's we call as acute lah. And if chronic conditions such as cystic fibrosis and also lung cancer. Okay, so about the pulmonary system, so the assessment of pulmonary status generally starts with physical examination using percussion and also auscultation. So contohlah bila nak check macam mana ada any disorder, so dia akan check lah, dia akan check using stethoscope kan, dia tengok ada tak any bunyi ke kan, terasa macam ada wheezing ke kan, or they can just tap into your lung kan, nak tengok kan. That is the start of the assessment lah. So these bedside techniques provide important information to the clinician on the breathing. And numerous diagnostic and monitoring tests such as imaging procedures, so they can check whether there's inflammation of the lung, is there any water ke dekat lungs kan, and using arterial blood gas determination. Arterial dia akan ambil dekat sini kan, dia tengok blood gas, this is to measure the gas lah. So usually doktor akan check using arterial blood gas, sputum cultures and also biopsies. This is among the diagnostic test to determine diagnosis, to determine the correct diagnosis of the pulmonary disorders. So here is the sign and symptoms of pulmonary disease. So the coughing, early satiety, anorexia, loss. Macam mana, kenapa ada anorexia and weight loss? Because usually those yang ada pulmonary disorder, they couldn't eat. Minum pun tak boleh, tersedak, tak selera ya. So it can lead to anorexia and also weight loss. Dyspnea, they are feeling shortness of breath, bila tak boleh nak tidur ya. Ataupun nak bernafas tercungap-cungap. And that's why kan, kalau kita boleh monitor kita punya oxygen kan, kalau we know that is below 95%, so you will experience difficulty to breathe, yeah? And then fatigue, yeah? This is among the common sign and symptom of pulmonary disease. Tapi sign and symptom ni macam sama juga dengan other disease as well lah, ya? Yang part yang anorexia and weight loss, part yang involve coughing kan, and also dyspnea ni, so selalunya it is related to pulmonary disorder. Okay. So about our pulmonary system, the pulmonary function tests are used to diagnose or monitor the status of lung disease, and they are designed to measure the ability of the respiratory system to exchange oxygen and also carbon dioxide. So macam mana cara nak measure dia? The easiest is we use pulse oximetry. Masa tengah teruk dulu COVID kan, ramai kan yang beli yang dekat jari tu kan, nak tengok pulse oximetry ya. So we call it as pulse oximeter. It is a small device it's actually use light wave to measure the oxygen saturation of the arterial blood. So we place it at the end of our finger. So the normal reading for young and also healthy people is about 95% to 99%. Or else you boleh pakai jam lah, macam saya pakai jam, smartwatch, or smartwatch also we can monitor our oxygen lah, blood oxygen sama ada normal ataupun tak. And so it's a sign lah kalau kita tengok, especially when you know that you are feeling unwell, kan, you batuk-batuk, tak sihat, demam kan, then you monitor your oxygen and then you see that your oxygen is below 95%, so there might be something wrong lah, that need future assessment. Okay, that is pulse oximetry. It's very simple device used to monitor our oxygen saturation. Other than that is spirometry. This is also a common pulmonary function test which involve breathing into a spirometer that gives information on lung volume and the rate at which air can be inhaled and also exhaled. So spirometer ni bila kita tarik nafas and then we exhale, kita hembus sekuat hati lah, and then baru tengok kat situ berapa besar kita punya lung volume. So those yang normal, they have a big capacity of lung lah, dia boleh inhale banyak dan dia boleh hembus kuat. Tapi those yang ada pulmonary disorder, paling senang orang yang ada asthma, so mungkin dia punya capacity, lung capacity tu is not that big, so dia nak exhale pun tak kuat mana. Okay, ini contoh gambar lah ya. This is example of ni macam old school punya pulse oximetry ya. Nowadays we have oximeter yang comel-comel tu ya. Tapi kalau yang very cheap tu kan, yang harga bawah RM10 or belas ringgit tu, it may not be that accurate lah. However, pulse oximeter is not that expensive. It's inexpensive, it's non-invasive. That can be used to monitor our blood oxygen level. So basically macam ni lah contoh. Okay, this is a spirometer. So cara nak guna dia, selalunya dia buat assessment ni kat those yang ada pulmonary disorder lah, macam ada asma kan. So dia minta patient to ambil deep breath and then blow as hard as possible into the tube. So dia akan tengok nanti kan berapa banyak yang dia dapat blow tu untuk tengok dia punya capacity, lung capacity. So this is a normal blood gas value. Kan tadi ambil kalau check darah daripada arterial blood gas, so they can check lah whether the blood gas is normal or not. I think according to the partial pressure of oxygen, partial pressure of carbon dioxide, they can also check your pH value whether it's in the normal range or not. Oxygen saturation that we can check using this oximeter and also bicarbonate. This is among the biochemical indicator lah for blood gas. Okay, so I hope sampai sekarang all boleh follow ya. So we already touch about the we recaps about the anatomy of our lungs ya, and then about the blood gas. Okay, now baru kita nak move kepada dia punya medical nutrition therapy. So when we talk about MNT with pulmonary disease, we always associate this with malnutrition. Kenapa? Because malnutrition associated with poor intake, it will reduce the strength and endurance of respiratory muscle and also the lung parenchyma. And continued malnutrition increase risk of infection. So this malnutrition, it will adversely affect our lung structure, the elasticity and also the function, the respiratory muscle mass, strength and also endurance, and also the lung immune defense mechanism and also the control of our breathing. Contohnya, kalau ada protein and also iron deficiency, it will result in low hemoglobin level, which diminish the oxygen carrying capacity of the blood. Okay, so kalau ada low levels of calcium, magnesium, phosphorus, potassium, they will compromise the respiratory muscle function at the cellular level. So malnutrition dengan we don't want malnutrition to happen lah, because it will affect our lung. Okay. Mounting evidence correlate the role of dietary antioxidants with healthy lung function. So kalau contohnya cigarette smoking associated with reduced level of antioxidants. So banyak study lah cakap untuk healthy lung ni we need antioxidant. Antioxidant you can be find macam-macam lah, daripada vitamin C, vitamin E, makan buah. So that's kind of antioxidant. However, when if the patient exposed to cigarette smoking, whether it's either it's active or passive smoker, it may reduce the level of antioxidant. So itu pun benda yang kita perlu tengok juga. And then respiratory disease may affect dietary intake. Macam mana dia affect? Because of the early satiety, cepat rasa kenyang kan, tak ada selera nak makan ke kan. And then anorexia, weight loss, cough and also dyspnea during eating. Kalau nak rasa nak makan pun penat, tercungap-cungap kan, macam mana. So it can lead to malnutrition lah. Dan macam saya cakap tadi lah, kita orang biasa kita nak bernafas senang. Tapi kalau orang yang memang ada masalah, dia nak bernafas pun dia require high energy. So here is the list of effect of malnutrition on the pulmonary system. So pulmonary disease substantially increase energy requirement. This is saja mention tadi kan. Then it will increase the energy requirement. Because our body need more. Because to breathe, nak bernafas pun it requires energy. So this factor explain the rationale for including body composition and weight parameters in medical, surgical, pharmacologic and also nutrition research studies. So weight loss from inadequate energy intake is significantly correlated with a poor prognosis in persons with pulmonary disease. Malnutrition leading to impaired immunity places any patient at high risk for developing respiratory infection, and malnourished patients with pulmonary disease who are hospitalized are likely to have lengthy stays and are susceptible to increased morbidity and mortality. Okay. So this table is summarized. Increased energy expenditure. Kenapa increased energy expenditure in people with pulmonary disease? Because increased work of breathing. And then can be due to chronic infection and also medical treatment such as bronchodilators, chest physical therapy, etc. And reduced intake how they reduce intake. Kenapa? Sebabnya mungkin dia ada fluid restriction. Maybe they have edema, mungkin ada air dalam paru-paru, ya. So they restrict their water intake, ya. So eventually, sometimes when they reduce their fluid intake, also can lead to malnutrition. And then reduced intake can be because of shortness of breath, tak boleh nak bernafas, ya. And decreased oxygen saturation while eating, ya. Anorexia resulting from chronic disease, and also GI distress, and also vomiting. Okay. So additional limitations that can lead to malnutrition is due to the difficulty in preparing food due to fatigue, lack of financial resources, impaired feeding skill, altered metabolism, and also food-drug interaction. Okay, dapat ya? So ini semua macam how you're going to explain lah ya, kalau ada soalan tanya ya, how to relate malnutrition and also nutrition. This is due to this lah ya, kenapa ya? Okay. So pulmonary aspiration involves the movement of food or fluid into the lungs, which can result in pneumonia or even death. So beside liquid, foods that are most easily aspirated include those that have a round shape, such as nuts, popcorn, hard candy, hot dog, or chunks of inadequately chewed food such as meat or raw vegetables. Ya, contohnya selain tu macam kalau dia makan anggur pun kan, dia bulat-bulat macam tu kan. Ya. So this also can increase the risk of pulmonary aspiration. Ya. So infants and toddlers are at increased risk for aspiration, ya, as are older adults and person with oral, upper GI, neurology ataupun those with muscular abnormalities also increase risk of pneumonia aspiration. Yeah. So because the primary reason for aspiration pneumonia is excessive lung secretion, pulmonary treatments and suctioning are critical to prevent aspiration. Yeah. So kalau I sebut apa pulmonary aspiration, so this is a kisah ya, bila dia macam sebenarnya tersedak lah ya, but tersedak yang pulmonary aspiration tersedak yang boleh menyebabkan dia tersedak sampai masuk dalam paru-paru balik ya. So this can lead to lung infection ataupun kematian ya. Okay. So now let's move to asthma. Tadi tu kita just bagi penerangan ya, and I introduce you to the terms ya, macam pneumonia tadi ya. So now let's check it, asthma. Okay. I believe that asthma is a very common disease, ramai yang ada asthma ya, tapi kadang kita tak tahu apa kaitan asthma dengan nutrition kan ya. So asthma, this is actually a disease of bronchial hyperresponsiveness and airway inflammation. So asthma is characterized by airflow obstruction and is one of the leading cause of hospitalization and death worldwide. Dan so kalau kita tengok kat sini gambar ni, okay, gambar ni, and this is the normal airway. Nampak kan dia elok, dia kan boleh lurus, dia ada dia punya airway dia luas kan, boleh masuk kan. I mean cakap luas pun, the airway is very small lah, but you compare with asthmatic airway. Ya. Kalau asthmatic, ya, dia ada inflame kat sini, ada inflammation kat sini. So laluan dia pun sempit, kan? So this is the wall inflame and also thicken. Ya. Tapi kalau during attack, dia lagi lah, dia memang dah kat sini, tengok dia makin inflame kat sini, dia makin macam kecil je. Ya. And then dekat dia punya smooth muscles, it tighten. Ya. So itu yang kalau orang yang complain ada asthma, dia feel that dia punya chest macam rasa ketat, nak bernafas susah ya, nak bernafas susah. Kenapa? Sebab daripada normal airway like this, it becomes like this. Ya. Orang ada asthma memang airway dia kecil sikit lah, so dia susah nak bernafas, dia rasa ketat dada dia, and when dia burst, ya, dia akan ada bunyi wheezing biasanya. Okay. So the pathophysiology, so the syndrome appears to result from complex interaction among genetic, immunologic, and also environmental factors. Okay, so it is characterized by increased mucus secretion that can obstruct the airways, yeah? Inflammation and swelling, and smooth muscle tightening that results in smaller airways. Ya. Ni ingat balik yang image tadi lah, ya, characteristic of asthma. Ya, apa jadi ya? Basically we can see the characteristic at the airways lah, ya. Seperti mana compare dengan yang normal, ya, macam mana yang ada pulmonary yang ada asthma ni dia jadi sempit, iaitu ya, dia ada due to inflammation. So genetic attributes, ya, contohnya macam ada parents ke pakcik-pakcik yang ada asthma, ya, so you have to risk lah. Environmental exposure, ya, sometimes people they are not born with asthma, ya, suddenly due to the environmental banyak sangat terdedah dekat asap ke, for example, kan, ataupun bulu kucing ke, sometimes it can also lead to asthma, ya, and also gene environmental interactions that all play in the role of asthma, ya. So asthma ni kita boleh bahagikan dia kepada dua, ya, sama ada dia allergy ataupun non-allergy, ya, because sometimes orang yang ada asthma ni dia ada allergic juga, ada yang tak ada. So kalau allergic asthma, allergic is extrinsic, ya. So basically it is more common. It is generally triggered by inhalation of pollen, bad air pollution, cigarette smoke, and also other inhalants. Yeah. So itu kalau extrinsic lah, ya. So macam dia bau je pun dia boleh terkena asma contohnya, kan? Ataupun non-allergic asthma that is maybe triggered by factors such as ear infection, stress ke, kan, ya, so it can also be triggered lah dia punya asma juga. And sometimes orang yang ada asma ni dia punya symptoms boleh aggravated by exposure to allergen. Contoh allergen macam udang seafood, ya, ataupun dust, habuk, kan, dia pun akan sensitif lah, ya. Contohnya, bagi contohnya, kalau orang yang ada asma lah, kan, biasanya dia bau habuk sikit kemar-kemar rumah, dia dah terus bersin-bersin, dan lama-kelamaan boleh trigger dia punya asma, dia rasa attack, ya. This is because of dia ada dalam kategori orang asma yang ada allergy contohnya, ya. So those with obesity, kan, we know that obesity also can influence the asthma risk, yeah? And although the link of obesity with asthma ni, they are unclear, yeah, they are rather low. Recent meta-analysis conducted that the high body mass index is associated with significant increase in relative risk for subsequent asthma. Basically kalau orang yang overweight ni memang banyaklah dia punya risiko untuk dapat ada disease as well. Okay. So about the clinical manifestation of asthma. Okay. So they have recurrent episodes of coughing, wheezing, breathlessness, and also chest tightness. This is the common asthma lah. So you can progress to respiratory alkalosis and also respiratory acidosis. Yeah? So the cornerstone of asthma management is medication therapy. Yeah, medication therapy, it can be in terms of inhaler, yeah, bronchodilators, and also corticosteroid, yeah. So kalau bila-bila kita perlu, kan, selain inhaler, kalau perlu boleh juga ambil my mumps, yeah. However, these problems can also involve food medication interaction, obesity, GI reflux disease, food allergy, and also other issues. Yeah? Therefore, individualized medication therapy is warranted. And finally, counseling to achieve a healthy balanced diet is recommended for overall health and also weight management. Okay. 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 So about asthma, so increase in asthma is parallel with obesity rates. Although dia punya reason for relationship is unclear, but we can see that those yang obesity, overweight, they are more prone to asthma. So they have a protective effect of breastfeeding. Studies show that those breastfeed infant, breastfeed child, they have the breast milk there might have a protective effects towards asthma. And then food and nutrient, individual nutrient, they may also have possible roles in the treatment of asthma. Contohnya macam leukotriene, it can increase the omega-3 fatty acid to interfere with the omega-6 metabolism. Antioxidants such as vitamin C that has a really strongest association with asthma. And so we can remove known triggers. A variety of medication may have nutritional side effect. So actually banyak lah kalau nutrient-nutrient lain yang membantu untuk asma, not only the antioxidant tapi soy, for omega-3, which this one can they can decrease the production of bronchoconstrictive and also leukotriene. Antioxidant, antioxidant macam vitamin C tu, it can protect the airways tissue daripada oxidative stress. And then vitamin D, the molecular anti-infective nutrient. Magnesium, magnesium a smooth muscle relaxant and also an anti-inflammatory agent. Ini semua adalah contoh-contoh lah. So we receive a lot of question, orang yang ada asma. Does milk cause an increase in mucus production in asthma? You always heard this. However, literature review found no cause-effect relationship, and avoiding dairy foods could lead to inadequate intake of nutrient. So, until relationship between diet and asthma understood, we should control our weight and also encouragement of breastfeeding to our babies. So itu untuk protective dia lah, untuk immune. So this table, it provides you the medication and also the nutrition related adverse side effect. Kalau apa makan, apa ubat yang diambil lah. So nanti ni you boleh baca sendiri lah. Semua. Okay. Dan about asma. Okay, kita patah balik sekejap pasal asma tadi. Okay. Saya dah masuk COPD. So basically kalau nak cakap diet pasal asma, MNT for asma is not that much. Basically kalau untuk asma ni, kalau orang akan tanya banyak benda lah orang asma. Orang asma boleh ke makan buah tembikai? Okay, what is your answer? Buah sejuk. Okay. Maybe ada sesiapa boleh jawab tak? Bila kita cakap pasal asma kan, sebab I tak sentuh sangat pasal MNT, because MNT for asma is actually nothing much. We just kita tengok apa dia punya underlying disease as well lah. So I nak tanya opinion lah untuk daripada you all. Orang asma tahu, orang asma selalu dia susah nak bernafas lah. Okay. And then ramai yang tanya I juga, okay, orang asma boleh tak makan buah tembikai? Orang asma boleh tak makan buah anggur contohnya? Siapa nak jawab? Siapa ada opinion on this? Sebelah panggil nama lah. Okay, cuba. Siapa nak jawab? Apa pendapat you all? Kelas rap mana kelas rap? Fatin kan Fatin. What is your opinion, Fatin? Can asthmatic people, they eat grapes, watermelon or such fruits that we call as cold food. Ya, bolehkah kita makan benda-benda tu? Orang yang ada asma. Fatin, apa opinion you? Mana Fatin?
Tidur.
Okey, saya rasa boleh. Kenapa? Ceritalah sikit. Boleh sebab buah antioxidants. Such a nice answer. Okay, other people ada try? Anyone who wants to try? Ataupun perhaps kalau orang yang ada experience lah, ada tak siapa yang ada asma kat sini? What is your opinion? Can those people with asthmatics, they consume such kind of food? Siapa lagi insan bertuah pada hari ini? Siti Sarah ada, Siti Sarah Maknawi. Siti Sarah Maknawi dah? Mana mic you all? Okay, Siti Sarah Maknawi rasa boleh, kenapa? Dia kata okay, buat antioksidan. Okay. Oh, mic saya problem. Okay. Okay, Siti Sarah. Okay, siapa yang tak ada masalah mic? Okay. What do you think? What is your opinion bila dia tanya? Boleh tak nak makan ni? Okay. Tak payah panggil orang lain lah. Kebetulan I ajar you apa dengan URTI ni duk batuk, tak berhenti sakit tekak ni. Okay. And I'm also asthmatic. I memang ada asma daripada kecil lagi. Ya. Emmanuel ada, Emmanuel yang layang. Ada? Are you here, Emmanuel?
Hello, doctor. Sorry.
Okay. Yeah, okay, it's okay. Okay. So what is your opinion, those asthmatic person? Can they eat such kind of food?
Sorry, can you repeat the question?
Okay, those yang ada asma ya, ada asma. So asma is always related with milk dan susu, and then those cold food macam tembikai, grapes. Yeah, people say that we cannot, those asthmatic person we cannot consume that kind of food, yeah, because they can trigger their asthma. So what is your opinion? Can they consume such kind of food or fruits ataupun tidak?
In my opinion, I think yes. Because I'm not so sure.
Okay, I'm not so sure. Okay, so now semua tak sure. Okay, so I give you the answer. Yeah, this may not be the correct answer lah, tapi this is what we should practice. Okay, kalau kita tanya, boleh ke orang asma makan buah anggur, makan buah tembikai? We can say that yes, you boleh eat. Yeah, even though dia kata susu, ya, banyak yang cakap susu they can increase mucus production in asthma. Ya, so orang cakap kena avoid. Tapi there is no such strong evidence base that say that orang asma tak boleh minum susu, orang asma tak boleh makan buah ni, tak boleh makan. So our answer is yes, you boleh makan, tapi kena ada tapi. Ya, kalau you makan tu, orang yang ada asma, kalau you memang makan buah tembikai contohnya, and then you dapat asma, so please avoid. Janganlah kata boleh. Ya, janganlah you paksa juga dia makan, sebab kalau dia makan memang boleh trigger dia punya asma. Yeah. So I give you my example because I am an asthmatic. Yeah. Alhamdulillah I tak ada allergic dengan makan lah. Yeah. I allergic to dust, tak boleh berhabuk lah. Habuk will trigger my asthma. So I have no problems in food. I can eat like usual lah. But I have problems in shrimp. I punya asma akan trigger dengan udang. Which is udang yang tak fresh. So I pandai lah pasal udang. Kalau I makan udang yang tak fresh tu, I akan sakit dada sikit kan, udang yang tak fresh, ataupun akan gatal, naik eczema terus kalau makan udang tak fresh. Tapi kalau udang fresh, I boleh. So now I know my allergens. Yeah? So itu untuk orang asma. Dan kalau dia tahu dia makan tembikai and then dia akan trigger dia punya asma, so you have to say no. Banyak lagi buah yang ada antioksidan, yang ada vitamin C yang lain. If dia punya asma akan trigger with eating grapes, so please avoid grapes. So that is our answer. So tak boleh kita nak samakan dengan semua orang yang ada asma. Asal dia ada asma, dia kata tak boleh minum susu sebab dia akan trigger mucus. Tak boleh makan tenggikai sebab dia sejuk, boleh sebabkan asma. So no. So it really depends on the patient. So what you can do is you have to assess the patient lah. So you should identify apa dia foods atau yang always associated with asthma. Contohnya macam susu, susu dia akan increase mucus. Contohnya buah-buahan sejuk, memang buah-buahan sejuk ni selalu dia dikaitkan dengan allergen dekat orang yang ada asma. Dia sejuk lah biasanya, dia selalu lah dikaitkan dengan asma. So you should assess that. Kalau dia kata tak ada masalah, so you can just eat like usual. Tapi kalau dia kata benda-benda tu itu adalah penyebab dia, memang lepas minum susu dia banyak kahak, dia kata. So you have try to avoid lah. Walaupun tak ada evidence base yang cakap yang dah terbukti yang orang ada asma tak boleh makan such food. So itu tugas kita dietitian lah. Kita tak boleh kata tak boleh ataupun ini memang boleh makan ni, jangan macam tu. So kita human kita negotiate dengan our patient. Okay, so I hope that I answer you clearly lah pasal apa persoalan ni, sebab nanti akan ramai orang tanya you all. And you will hear daripada macam-macam orang akan cakap lah, ni tak boleh makan ni, orang asma kena makan hati unta, orang asma kena makan ikan haruan, for example. What is the evidence behind that? There is no evidence behind that. Tapi kalau kita memang tahu benda tu tak boleh makan because it will trigger the asthma, so just stop. Okay. So that is about asthma. Sorry. Okay, next we move to BPD. BPD or bronchopulmonary dysplasia. So the definition, the chronic lung disease of prematurity, the pulmonary inflammation, impact growth and also development of alveoli. So kalau kita sebut pasal BPD, BPD is dia punya assignment, dia punya case study is about BPD. So the chronic lung disease of prematurity, CLD ataupun BPD ni dia adalah lebih kurang lah, they are closely related. And it's usually appear to the newborn lah, because our newborn lungs, especially the immature lung, those babies born premature, they are unable to respond to the adverse situation. So the immature lung, they often cannot synthesize surfactant that permits inflation for gas exchange. So the etiology is complex and multifactorial, and it includes genetic factors, infection, pro-inflammatory cytokines, oxygen toxicity, ventilator trauma, and also vitamin A status. So this is about the BPD. Okay. So BPD ni dia adalah lung disease in usually in infant lah, chronic lung disease, bronchopulmonary. So CLD dengan BPD ni dia selalunya jadi dekat infants yang extremely premature. Maknanya lahir tak cukup bulan. Normally baby lahir at 37 weeks. Ni baby yang lahir extremely premature. Contohnya 6 bulan dah lahir, 7 bulan dah lahir. And then berat badan pun yang very low birth weight. Kalau normal biasa orang lahir 3 kilo kan, above 2.5 kilo. Baby dia lahir 2 kilo, 1 kilo lebih saja, yang very small. So they often have this CLD ataupun BPD. And other risk factors of BPD termasuklah perinatal infection, infection at the mothers, that can then goes to the babies, meconium aspiration. Meconium aspiration ni contoh maksudnya bayi dah tertelan najis, tertelan meconium. Macam mana baby boleh tertelan najis? Baby dia dah terbuang air dalam baby kan dalam kantung kan, dia dah buang air, so dia makan sendiri najis dia. So one of the risk factors, ada fistula ataupun ada infections, that can be the risk factors of BPD. So kalau orang yang ada BPD ni dia punya sign and symptoms macam Macam sama macam lung disease lain, dia ada hypercapnia, tachypnea, ya, wheezing, dyspnea, ada recurrent respiratory infection, ya. And that's all the sign and symptom of BPD lah. So when the patient ataupun when the infants diagnosed with BPD, usually they will be given mechanical ventilation. Dapatlah support kan pakai oksigen tu. And in terms of nutrition, they will be provided with parenteral and also enteral nutrition support. Why? Remember lah, BPD ni dengan CLD sebenarnya dia occur dekat baby. Infant, premature infant kan. So nak makan, nak minum susu pun tak pandai lagi, nak sucking, nak isap susu pun tak pandai kan. So we provide them with parenteral and also enteral nutrition supports. So good prenatal care to prevent premature delivery and use of prenatal steroids if premature delivery expected. So what is this prenatal steroid? So tadi I sebut kan pasal kalau infants yang premature ni, they cannot develop enough surfactant. Surfactant yang boleh bantu untuk gas exchange tu kan. So when we expect that the mother will deliver prematurely, so doktor boleh bagi prenatal steroid. Dia akan inject lah steroid that SAR tu, so with that steroid it can help the surfactant produce the production of surfactant from the lungs, so dia boleh bantulah gas exchange. So selalunya dia akan bagi steroid ni 2 kali lah before ibu tu delivered. Tapi ada setengah kes juga kan, ibu tu tiba-tiba dah nak terbersalin premature, tak sempat nak bagi DEXA, so tinggi dah sikit risk BPD kepada dia punya infants tu as compared to mothers yang receive complete steroids. Ni contoh gambar infant receiving supplemental oxygen. Ni kesian kan baby, tapi baby dia teman-teman gemuk-gemuk macam comel ni, baby Mak Saleh kot, walaupun kecil nampak sedap berisik. This is baby on ventilator. Ni baby on CPAP, continuous CPAP. Ini baby yang on air lah, yang on nasal prop. Okay. So about the nutrition assessment and also diagnosis. So growth failure due to decreased nutrient intake, increased requirement, hypoxemia, delayed skeletal mineralization and also osteopenia. So untuk infant that is diagnosed with CLD, biasanya dekat NICU, we have to follow the growth closely because it is a major outcome indicator of the medical and also nutrition therapy. Sebab kalau kita tak boleh nak measure dia punya size of lung kan, so kita measure dia punya growth lah. Kalau baby kita measure dia sama ada naik berat tak kan, memanjang ke tak, so we can tengok dia punya growth chart lah, refer to the growth chart. Sama juga nanti you all dapat case tadi, please refer to the growth chart. And then there is the anthropometry, and the complete nutritional assessment is important. So nutrition assessment selain daripada anthropometry tu, you can measure dia punya susu lah, intake susu dia berapa kali dia ambil, ada muntah ke tak kan, etc. Okay. So this is the nutrition assessment yang you boleh tengok lah from the history of the birth weight. So kalau baby dah memang lahir very underweight kan, very low birth weight kan, so you tengoklah dia punya growth tu macam mana. And then gestational age, is the birth weight tu appropriate to the gestational age or not. Some baby kan mungkin dia lahir 1 kilo, tapi 1 kilo tu memang sebut masa 24 minggu, so the birth weight tu is appropriate with the gestational age. Okay, lainlah kalau macam baby lahir umur 32 minggu, 8 bulan, tapi berat baru 1 kilo, so mungkin itu dia tak appropriate with gestational age. So please refer to the growth chart lah and check whether kita ada growth chart untuk prematurity, and then you can check lah whether dia punya line tu dekat mana. And medical history, is there any other disease kan, the nutrition history, and also previous growth pattern. Other than that, you can check also the medical status, The respiratory status, oxygen saturation, use of medication, emesis, stool pattern, etc. And then the nutrition, biochemical measures such as the anthropometric, and also biochemical. And then here, feeding history. This is important for you to see. Ini kita punya kepakaran lah. We can see the volume of intake. Cukup tak dia punya susu, amount susu tu, berapa kali dapat kan, berapa banyak sekali dapat. And then frequency of feeding. Usually kalau dekat NSCU we give them kalau 8 kali sehari lah, every 3 hours ya. How about breastfeed, tak breastfeed on demand ya. And then behavior during feeding, how about the formula composition, the use of solid food ya, any swallowing difficulties ya, etc. Okay. And then the environmental concern ya, macam facilities ya, parent-child interaction, economic resources, access to foods and nutrients lah ya. So kalau this is how we do the nutrition assessment lah. Okay, so the possible reason for growth failure among infants ya, dan termasuklah increased energy needs ya. They have an increased energy needs but they have inadequate dietary intake, plus ada gastroesophageal reflux, ada chronic hypoxia. So that is the possible reason lah why why there is growth failure in the children. Okay, so growth should be evaluated and compared with that of other infants of the same post-conceptional age. So infants yang ada CLD, yang ada BPD ni, they have special short and long-term nutritional requirements related to both their prematurity and also their pulmonary status. So our goals, our MNT goals is we want to adequate nutrient intakes and then we want to promote linear growth. Kita nak dia naik je, graph dia naik je. Kita tak boleh nak shoot dia terus naik sama macam orang baby yang tak ada masalah ya, ataupun baby yang born at normal term, at term kan ya. Tapi kita nak dia ada linear growth. And then we can maintain their fluid balance and develop age appropriate feeding skills. Okay. So the provision of energy and macronutrient for BPD, they are 15 to 20% higher than healthy infants. 15 to 20% higher. Dia punya calorie is about 120 to 130 kilocalorie per kilogram body weight per day. Dan protein is about 3 to 4 gram per kilogram per day. So this is generally what is the energy needs for the infants. Okay, so and vitamin A, about 1,500, and then we closely monitor the electrolyte balance and sufficient minerals for bone growth. So basically kita akan tengok dekat energy ni lah ya. So sebenarnya cara paling senang lah ya untuk dietitian monitor baby dekat NICU, baby premature, baby with BPD ni, kita tengok berat badan kan ya. So energy needs tu memang higher lah, then we can monitor lah whether also cukup tak susunya, tak kenaikan berat badan macam tu ya. So energy needs is higher compared to healthy infants. Okay. Okay, this is the summary lagi lah ya, sama ya. So increased needs for infants with bronchopulmonary dysplasia. Okay, so supplement maybe need ya, doktor akan tentukanlah sama ada perlu tak supplements ya. So usually kita akan start dengan parenteral nutrition ya. So masa tu mungkin energy need, energy requirements is rendah lah kan, and then bila dah when the infant is growing rapidly then we can increase the energy requirement, and we can increase the energy intake. Okay, so basically it's about 120 to 130 kilocalorie per gram ya, ataupun boleh juga lebih. Kalau kita tengok baby tu boleh accept dah, dia boleh dia terima lah kan, tak ada masalah kan bila makan. So you can just boleh bagi sikit-sikit lebih lah ya. Okay. Okay. So So the BPD, the feeding practices is nutrition support transition to bolus feeding, so from parenteral nutrition, so kita nak pergi kepada nutrition support, pergi bolus, and then of course we always promote breast milk, kalau baby yang dah besar sikit, infant yang dah boleh hisap, kita minta dia cuba untuk breastfeed, so they must have transition lah, they may need fluid and sodium restrictions, depends whether they require or not. And for BPD, they have specialty infants formula. Some may require specialty formula, specialty infants formula yang hypercaloric, contohnya untuk orang yang baby yang severely extremely low birth weight ni, dengan babies yang premature, dia ada formula untuk premature baby, which is formula tu dia provide more calories. So breast milk is preferred to reduce so necrotizing enterocolitis. So we always encourage mothers to give breast milk. So mothers yang ada anak premature, tak boleh nak direct breastfeed, so we encourage mothers to express their milk. So simpan lah, kena ajar lah cara mak tu macam nak handle susu perahan, and then give to the baby. And then we can also use human milk fortifiers added to breast milk to meet needs of premature infants. So I tell you that those premature infants yang low birth weight, yang ada BPD, they require additional energy, they require higher energy intake compared to those normal baby. Tapi diorang ni perut pun kecil, tak boleh takkan nak bagi berapa banyak sekali bagi volume kan, takut tak boleh terima, so macam mana dia nak meet dia punya requirement of high energy tu is to use the human milk fortifiers. So human milk fortifiers ni is dia macam dalam powder form, kita tambah kepada susu, so it will increase the energy of the milk. Okay, and then we provide education and support to caregivers. Okay, so tapi kalau human milk fortifiers tu namanya pun HMF, memang untuk susu badan lah. Tapi kalau dalam susu biasa kan, susu biasa, susu formula biasa, maybe we can add on Kabori kan, that is to increase the energy. Or kalau mak tak boleh susu badan, dia guna specialty infant formula, susu yang khas untuk preterm, that kind of food memang ada higher calorie. Okay. So feeding difficulties frequently occur among infants with CLD and also BPD. So the risk factors include history of unpleasant oral experience, for example just post into baru extubate kan, frequent suctioning or recurrent vomiting, history of parenteral and enteral nutrition, delay introduction of solids, discomfort or choking associated with eating solids, and then infants may tire easily while breastfeeding or bottle feeding. So this is the risk factors lah, So maybe these infants, they are very small, they are tiny, so nak breastfeed ni ada satu kerja yang susah untuk diorang, so dia akan feel tired. So that's why lah kalau macam baby-baby yang infant, very small infant ni, kita memang bagi dia bolus feeding dulu. Breastfeed tu try kejap-kejap lah, because breastfeed ni pun dia penat, nanti akan lagi cepat dia turun berat badan kan. So we provide them with bolus feeding pakai tube, and then selang-seli lah ajar dia untuk direct breastfeed, sebab tak nak dia penat sangat. Okay. So useful approach that facilitate feeding acceptance include providing a pleasant and calm mealtime environment, providing oral stimulation during tube feeding. Contohnya maksudnya bila dia makan pakai tube feeding can be tube nasogastric ataupun orogastric kan, tak salah hidung ke mulut kan. So bila dia minum susu tu tuang, so you can provide oral stimulation lah, boleh main kat pipi kan. So dia macam baby tu macam mimic sucking method, and then using consistent and appropriate feeding techniques, and gradually introducing progressive texture and also flavor changes. Ya. So maybe dekat NICU ni kan yang ada BPD ni, sometimes kita bagi selalu nurse bagi tube feeding kan, tapi kadang kita bagi cup feeding juga ya. So sometimes we bagi dia isap pakai tube, yang tak boleh nak suck breast kan, direct breast ataupun bottle feed ya. So boleh bagi pakai syringe ya, bagi syringe letak kat tepi mulut kan, ajar dia macam mana nak isap pakai syringe ya. So there's a technique lah. It's very interesting to see how nurse lah usually nurse and mothers ya of premature baby yang ada CLD ni handle ya, approach lah baby untuk minum minum susu ya. So please read further on this topic ya. Okay, so do you have any questions so far? Ya, faham tak? Takut ada student tak clear pula pasal ni, because I think kejap guys, my slide I terus masuk COPD ni ya. Okay, so pasal BPD ni you have to read balik, you kena patah balik pergi topik yang belajar MNT for MNT untuk kids, untuk children pun you kena patah balik pergi kat situ, you tengok balik berapa energy requirement for kids for infants, berapa berapa kalori susu badan and then please also read about HMF human milk fortifier, dia provide berapa kalori human milk fortifier tu and then berapa kalori tu per satu sachet tu boleh ditambah kepada berapa ml susu. Please read because benda-benda tu penting lah. This is I just give you theory tapi nanti you all akan buat case study, so you akan I believe that you all will read in depth lah about this topic. Okay, settle pasal BPD. Now we move to COPD. Okay, so give me 2 to 3 minutes, kita relax sekejap before we move to next topic. Okay, kita take a break sekejap. Okay. Okay, so we continue terus. Tadi kita tengok pasal BPD, now we continue COPD. Okay, COPD, chronic obstructive pulmonary disease. So apa benda ni? So by definition it is a progressive disease which limits airflow through inflammation of the bronchial tubes or bronchitis or destruction of the alveoli or emphysema. So that is COPD. Okay, so ni gambar COPD. Gambar je lah. So kalau chronic bronchitis nampak kat sini macam mana healthy ni. Ni kalau bila ada inflammation and excess mucus, this is chronic bronchitis, nampak macam asthma tu lah, dia punya airways tu inflame. Tapi kalau COPD ni dia chronic lah, dia sentiasa macam tu je kan, sentiasa ada excess mucus here. And emphysema, you can compare here between sac of alveolar, sac of healthy and also emphysema. Kalau healthy macam ni elok, cantik kan. Those with emphysema dia punya alveolar membrane is breaking down. Okay. So for COPD, they can be classified according to severity. The severity of the patient's airflow limitation based on post-bronchodilator FEV1. So this is the classification. COPD berapa lah? Mild to very severe. So FEV ni is the measure of the ability to take a deep breath. So apa faktor COPD ni is very common kalau tengok orang-orang tua kan, kadang tak berapa tua pun ada COPD. So it's actually the tobacco smoking, merokok lah ataupun sentiasa continue dengan second hand smoker. They are the primary causative factors. So macam environmental air pollution, genetic susceptibility, itu pun adalah possible causal factor of COPD. Okay, so the epidemiology, the primary risk factors is smoking. Tadi dah cakap lah. So other risk factors including air pollution, second-hand smoker, history of childhood infections, and also occupation exposure to certain industrial pollutants. Okay. So the etiology, kita divide into two lah, whether it's chronic bronchitis or emphysema. So the etiology of chronic bronchitis is productive cough and also shortness of breath. So it can appear 3 months each year for 2 years or more. So that is for chronic bronchitis. Patut tak berhenti. And then for emphysema, it can develop gradually, and inflammation that causing oxidative stress, and so deficiency of ATT. ATT is the alpha-1 antitrypsin. So it's a destructive actions of common illness and also exposures. So this is the etiology. So how about the pathophysiology? So for bronchitis, it is generalized inflammatory response to pollutants. So it will decrease the cilia tadi tu kan, it decrease the cilia function, so it increase phagocytosis and suppress the IgA. So the areas will thicken and the hypoplastic mucus glands, so it was unable to increase breathing enough to compensate. So this is the pathophysiology of bronchitis. Basically it's due to inflammation lah. The pollutant, chronic exposure to pollutant, merokok, lama-lama akan airway tu akan, so our lungs, the structure of the lungs, they cannot function well. So the clinical manifestation, so selalunya orang yang ada emphysema, yang ada COPD, dia punya by appearance they are always thin. They are often cachetic. So selalunya orang tua lah ya, dia ada mild hypoxemia ya, tapi hematokrit je selalunya normal je ya. So kalau itu untuk emphysema lah ya, tapi kalau patient yang COPD selalunya dia overweight ya, ataupun normal weight ya. So dia ada hypoxemia juga ya, and hematocrit values may be increased ya. So kalau chronic bronchitis, the clinical manifestation is decreased airflow rates, dyspnea, hypoxemia and pneumonia. Yeah, so the quality of life diminish. They may require supplemental oxygen and also copulmonal. Yeah, so copulmonal ni dia ada the enlargement of the right ventricular enlargement, yeah, and also failure of the heart. So that's what we call that. Yeah. So usually benda ni dia develops late lah in the course of the disease. Okay. So ini gambar cyanosis tadi disebutkan, dia punya manifestation including cyanosis ya. So cyanosis tu dia punya tangan tu kalau you perasan dia macam kebiru-biruan sikit ya, bluish discoloration of the skin. Kenapa dia jadi nampak bluish tu? Because it result from the poor circulation ataupun inadequate oxygenation of the blood. So itu yang menyebabkan colour macam tu lah ya. Okay. So for the emphysema, the pathophysiology is due to the destruction of lung tissue and loss of surface area. Yeah, so decreased surfactant, bronchioles collapse during exhalation and also traps air in the lungs. Okay. So kalau emphysema, dia punya clinical manifestation is decreased FEV, dyspnea, autopnea, hypercapnia, respiratory acidosis, barrel chest, extreme fatigue, exhaustion. Yeah, this is the manifestation lah. Yeah. So kalau orang yang ada COPD ni, whether bronchitis ataupun emphysema, there is no cure. Yeah, there is no specific cure for this COPD patient. However, our major goals of treatment is to manage the patient symptom. Yeah, so patient with reduced lung function, patients with COPD, they tend to have poor health that related to the quality of life. Yeah, so approximately most of the patient, they will also suffer with malnutrition. Yeah? So their breathing difficulties, they not only affect their exercise capacity, yeah, tapi they also will cause loss of appetite and also decrease nutritional intake. Okay. So for the treatment of emphysema, it include lifestyle changes. Okay. Smoking cessation and also avoidance of other pollutants. So we just avoid lah kan. Kita minta memang patient akan doktor lah, doktor akan minta untuk ubah lifestyle lah. Yeah. And then exercise as tolerated. Yeah. And then good nutrition, this is our part to provide good nutrition, because we, as possible, we try to avoid malnutrition, or if the patient already malnourished, that is our works lah, our task lah, to improve that nutrition. And then pharmacologic treatment, which include bronchodilators, steroid, and also pulmonary rehabilitation. This is among the medication used in the respiratory system. Either bronchodilators ataupun using steroid lah. Yeah. So kalau tengok ya, by using bronchodilators here, dia ada side effect lah ya. Among the side effect is nausea and also vomiting. Yeah. So sometimes patient yang ambil bronchodilators ni dia akan vomit. Yeah. So this is also will increase risk of malnutrition lagi. Yeah. So kalau steroids ni, can see dia punya side effect dia include ni. Most common side effect include sore mouth, hoarse voice, infection in throats and cough, ya. So itu pun akan menyebabkan susah nak makan ataupun minum. This is due to the side effect of the medication. Some patient tak ada apa-apa side effect, but some might have this kind of effects. And then those with antibiotics, pun ada risk of ada maybe akan dapat side effect of nausea, vomiting or diarrhea. Those on nucleotide inhibitors, headache, nausea, sama lah semua kat sini. And then cold flu symptoms is among the side effect of the medication. Okay, now we look at the MNT. So the primary goals of nutrition care for patients with COPD is, first is to facilitate the nutritional well-being. Second is to maintain an appropriate ratio of lean body mass to adipose tissue. Want to maintain appropriate lean body mass. Kalau boleh tak nak dia kurus sangat lah kan. And then correct fluid imbalance. Look at the medical record lah. Is there any fluid restriction ke? And then we look at the electrolyte punya chart kan. Tengok dia punya biochemical results kan. So if there's any abnormalities, so we try to correct that. And then manage drug nutrient interactions. Tadi dah tengok dah, there's possible side effects with all the drugs. And then we want to prevent osteoporosis. So this is our goal. So how to achieve this goal? Of course, kita provide energy and also nutrient. We provide them with sufficient lah, kita kira berapa dia perlu makan, berapa, but how tu penting untuk kita educate dia punya caregivers, we educate the patients and also even we educate the nurse macam mana nak bagi dia makan. We can always suggest our patient to take small frequent meals. Dia kerap makan, and every time eat, makan those food that is nutritionally dense. So minta patient makan bila patient rasa tengah sangat bertenaga lah, bila dia rasa dia sihat kan, when their energy level at the highest, ask the patients to eat. Kalau dia tengah penat nak makan macam mana kan, so bila dia rasa tengah ada tenaga tu, suruh dia makan. We provide with adequate calories semua tu, to achieve desirable body weight. What is our target body weight? Tak payah kalau underweight terus nak target BMI 22, tak payah staggered lah. We tidak dapat sampai ideal body weight. And then we can teach our patient to prepare food that require less preparation. Sebab tu you all belajar therapeutic diet kan. Macam mana nak sediakan makanan yang simple, yang require less preparation, senang, one pot meal for example, yang senang, boleh simpan, boleh panaskan baik dalam oven atau microwave. And then limitation of alcohol, ajar patient macam cara nak duduk masa makan, duduk tegak kan. Kalau orang yang ada high risk of aspiration, macam mana dia nak makan, So banyak benda lain sebenarnya yang kita kena tahu, we have to have knowledge on that, and that we can educate our patients and also the caregivers.
Tekan enter boleh tak?
Okay. So the nutrition assessment and diagnosis, so malnutrition, so malnutrition in patients with COPD is associated with cachexia, sarcopenia and also weight loss, and may result in poorer pulmonary functions, decreased exercise capacity and increased risk of exacerbations. So it is important, it is, kita memang minta, kita suggest lah to maintain a healthy weight for patient with COPD. So our complete nutrition assessment must include anthropometric measurement, compare dengan weight previous kan, and then their food nutrition related history, what kind of food that is best tolerated, Then medication use and also physical activity and also function.
Table masukkan kat lepas tu masukkan je. Sini kau buat
So
macam template aku buat.
because of for most people, kalau breathing is unconscious kan, effortless, but for patient with COPD, breathing require conscious effort. Nafas tercungap-cungap kan, so because of this added effort kan, tercungap-cungap tu kan, patient they can increase their resting energy expenditure and they can increase up to 10% to 15% more. So that's why if the patients they cannot compensate for the increased energy needs by adding more calories to their diet, they will lose weight. It's easily for the patient with COPD to lose their weight. So sebab tu kalau untuk requirement. Okay. That is requirement. So you should assess you should assess berapa dia punya, tengok dia punya berat waktu tu, and then you assess dia punya food nutrition history and then kita baru kita tahulah berapa sebenarnya energy requirement yang diperlukan. Okay, so basically generally memang dia akan about 1.2 to 1.3 from the resting energy expenditure lah. So because this is to compensate balik with the increased work.
Makan nasi lemak kan. Kita keluar.
Okay, this is the list of nutrition assessment kita tengok lah
Boleh lah.
Okay, so what is the intervention? The energy and nutrient needs is about 125 to 156% energy above basal energy expenditure.
Tak payah buat template.
So it's more.
Ada ke dia punya ni weh?
So about 1.2 to 1.7 gram per kilogram protein. So nampak protein intake is higher. So indirect calorimetry is the best method to assess calorie without overfeeding or underfeeding. So kita perlukan high protein. This is necessary to maintain or restore the lung and also muscle strength, as well as to promote the immune function. So kalau kat protein dalam 1.2 to 1.7 is about dalam 20%, 15 to 20% of calorie lah protein. Lepas tu fat about 30 to 45%. Karbohidrat tak boleh terlalu banyak untuk patient yang ada lung problem. So carbohydrate is just about 40 to 55%. Don't go up to 70% untuk patient COPD ni dia punya karbohidrat
Nak beli nasi campur.
because of the RQ, respiratory quotient. Nanti you all kita tengok apa masuk RQ. So this is generally what is the intervention nutrition therapy for COPD.
Boleh lah malam-malam. Aku makan memang sikit je.
Okay. So foods and nutrient delivery, foods that are good sources of both calorie and protein are also nutrient dense. So we suggest sebab tahu orang yang COPD susah nak makan kan, bukan saja penat nak makan kan, ataupun tak ada selera kan So we try to provide them food with energy dense and also protein dense, nutrient dense, lengkap kat situ. And then coordination of nutrition care such as physical exercise, because exercise equally important component of treatment. So the coordination of nutrition care ni we can coordinate with physiotherapy kan, dengan doktor kan, macam mana untuk provide physical exercise. Okay. So yang ini adalah planning nutrition intervention for individuals with COPD using the evidence base about the diet composition. We use patient preference to guide food suggestion. Because you want to, kalau boleh nak provide semua yang nutritionally dense food kan, tapi kita boleh tanya patient apa yang dia prefer untuk makan kan. About the medical food supplement, we can use a high variety of high calorie, high protein supplements to increase overall nutritional intake. So this can include modular supplements added to food or liquid supplement as an addition to the regular diet. And then vitamin, we assess the ability to meet the nutritional need. Ya, adakah perlu ke dia ambil additional sources of vitamin D, sources of antioxidant, perlu ke tambah? Ya. Tapi macam kalau patient yang continue merokok tak berhenti-berhenti juga merokok study says that additional vitamin C is needed. Kalau orang yang tak berhenti merokok tu. Because research indicates that people who smoke approximately 1 pack cigarettes per day, they appear to require additional ascorbate per day. So siapa yang isap rokok 2 kotak, jadi double lah dia punya keperluan ascorbate dia. So perhaps kita kena assess lah whether there's a need to supplement them with vitamin or not. Kalau tak perlu, tak perlulah. Okay. Apa ni? This is the summary of effects of nutritional supplementations on clinical outcome in COPD patient. I took this from the journal, Journal of Pharmaceutical Medical Association. Ni pasal effect of nutritional supplement lah. To the outcomes. Apa COPD status dia, apa nutritional supplement dia, whether it's high fat or high calorie. Omega 3, ada protein in terms of BCAA or protein in DHA, and also vitamin D. So apa clinical outcome dia kat sini lah. Kalau nampak kat sini, you can see that high fat food, it will improve lung function. Kalau high calorie food, but generally it will increase the body weight, fat free mass, increase hand grip strength, improve exercise capacity. Kalau omega 3, it will lower the TNF. So this is the effect lah, the summary of effects. So basically, kalau proper nutrition, it can help reduce carbon dioxide levels, and it can also improve the breathing. Specifically, it is also important to focus on the percentage of total carbohydrate, fat and protein that patient consume, to see how their diet composition impacts their respiratory quotient. Itu dia sebut pasal respiratory quotient. So RQ ni, dia adalah ratio of carbon dioxide produced to oxygen consumed. So to put it simply, kan kita bila kita makan ada metabolism kan, metabolism of fat, carbohydrate, protein kan. So this metabolism, it will convert it to carbon dioxide and also water in the presence of oxygen. Recall back your biochemistry punya kelas. Tapi ratio carbon dioxide kepada oxygen ni, it is different per macronutrient. Whereby the RQ for carbohydrate is higher compared to RQ for protein and also fat. So simply said that from the nutritional standpoint, eating carbohydrate, it will yield most carbon dioxide. Manakala kalau kita makan fat, it will yield the least carbon dioxide. So that is why it said that prescribing high fat, low carbohydrate, it will reduce the patient RQ and carbon dioxide production. So kalau patient yang ada difficulty in increasing ventilation, following carbohydrate load, or patients with severe dyspnea or hypercapnia, they may benefit from a high fat diet. So itu maksudnya kenapa kita cakap carbohydrate, the composition of carbohydrate, try to not give that too much lah, jangan sampai 70%. So always, usually the composition will be about 40 to 55%, and then protein is slightly higher, perhaps about 15 to 20%, and then the remaining is fat. Fat can go up to 40%. It's slightly high fat lah. Tapi some patients, they may have coexisting heart condition. So this would make high fat diet contraindicated. So you have to assess carefully lah. Kalau nak selamat, kita bagi just a normal normal composition lah, tapi study show that high fat may have benefits lah in the clinical outcome of COPD patient. Okay, so that is about the RQ. Okay, cystic fibrosis. Banyak lagi. Okay, so I think we will just stop at this before cystic fibrosis because sebab dah banyak dah kita dah tengok sampai COPD. Tak tahu sudah di still with me or not. I tengok makin sikit jumlah orang dalam kelas, dah ramai yang terkeluar and I don't record this session. So we will continue cystic fibrosis next week because eventually next week is class burn ke endocrine, tapi tak lama lah. I think that topic we can finish it within 1 hour. So I will continue cystic fibrosis topic next week together with the other topics. Okay, so nanti I will upload the assignment, case study assignment dekat YouFuture, so you can refer, so we can discuss it together next week. Okay, so nanti Fatin, please inform me when is the test. Is it next week ke ataupun this week ke? Macam mana nanti I will plan the slot lah to meet all of you again. Okay, so I will just stop it here. I tak nak continue sampai cystic fibrosis because it's too much slot. Okay, so if you have any question later you just contact me lah. Okay, okay class, we continue our lecture.